Good morning, respected chairman, teachers and colleagues. I am going to present a paper on stable pseudoarthrosis of long bones. Should it not be neglected? We all know the basic physiology of fracture healing varies from bone to bone, from fracture to fracture and from patient to patient. The two most important enemies of fracture healing are infection and non-union, which leads to mobility at the fracture site, and IITV examinations show stress in mobility and stress film X-ray are diagnostic, and we have followed these patients regularly at 6 months to 1 year interval. We have gathered such 20 cases, out of which 9 were fractured tibia, 5 were humerus and 6 were femur fractures. Physiologically, the age range varies from 20 years to 72 years. 5 were females and rest were males. 2 of the 5 females were postmenopausal, or 15 males were chronic heavy smoker and tobacco addict. Number of surgeries performed in an individual case range from 0 to 14 with an average of 4 surgeries. Duration of fracture non-union range from 3 years to 25 years with an average of 6 years, and all varieties of surgeries including plating, nailing, external fixator, repeated bone graft, plastic procedures, bone debridement, ELISA were done by various surgeons. These are some of the examples. Femur fracture, tibia fracture and upper tibia fracture, 28 years old, so mobility at the fracture site. 4 cases were HBsH positive and 12 cases were infected non-union. Our criteria for selection of patients were patients tired of or afraid of after repeated surgeries, old-aged patient, usually good soft tissue stability despite non-union, fracture gap less than 1 cm, overall alignment acceptable, physiologically acceptable, limited activities of daily life, and brace accepted by the patient. Surgical, economical and social familiar burden. Patients are exhausted completely by all means, and no neurovascular deficit in any of the cases. Active fracture disease was minimal or absent except mobility of the fracture site. These were the criteria for selection of the patient. Usually if such patient comes, we are tempted to do operation. But what to do if patient refuses for further surgeries because of the reasons we have discussed previously? Assess the fracture stability despite non-union. Never dishearten or threaten or reject the patient. Assess the fracture disease and surgical cycle. Reassure the patient's courage to continue activities, neglecting fracture and not the patient. Give mental support to patient and his family members. Provide physical support to the limb or brace, elastic support, caliper, etc. Gradual mobilization of the limb as well as patient is the motto. Start activities of the daily living and increase it. Minimize the physical support gradually and maximize the mental support. It's a team approach including clinician, physician, physiotherapist and psychotherapist. All patients had good non-weight bearing function, allowing activities of cooking, writing, combing, clothing and other daily activities of light weight bearing like foot accelerating or clutch or brake pressing while driving a car. 60% were able to perform weight bearing functions with external support or brace, while 40% were able to perform full activities including running, scooter driving without any support. The aim of study is to convey a message to facilitate nature's healing and rehabilitation process in such cases of non-union long bones where despite repeated sincere surgical attempts fracture refused and failed to unite. but lead to stable pseudoarthrosis offering good soft tissue stability leading to good functional outcome accepted by patient, and they were reluctant to accept any or adopt any sort of surgery. Our aim is to facilitate nature's healing and rehabilitation process in such cases of non-union of long bones where despite repeated sincere surgical attempts fracture failed and refused to unite but lead to stable pseudoarthrosis offering good soft tissue stability leading to good functional outcome accepted by patient when reluctant to accept or adopt any sort of surgery. To conclude, from this rare but definite group of patients, it is concluded that in these patients who are tired of surgeries and are reluctant for further surgeries, the remedy in the form of reassurance, patience, courage and confidence to continue activities and neglecting the fracture ultimately help them to come out of the fracture disease psychology and surgical cycle and encourage to continue more and more activities helping nature's rehabilitative process by providing stable functioning pseudoarthrosis. This is the first case, non-union of lower femur. The patient is able to stand and walk on the same leg. Another case, stable pseudoarthrosis of the tibia. Patient is able to bear full weight on the injured leg. This patient had 17 surgeries performed and still the fracture did not unite, and patient was walking on this non-union leg and there was no problem with the patient. You can see the video. This is another case, compound comminuted fractured tibia having lot of soft tissue injuries, grade 4, operated for the pedicle. The ultimately everything healed, but there was gap at the fracture site. We advised bone grafting. Patient did not accept the advice of bone grafting and started weight bearing, continued, and at the end of the 2 years the gap was filled by weight bearing action and the fracture was united ultimately. Lower end of the humerus, non-union, operated 4 times but failed. Patient is able to do all activities including heavy weight lifting. You can see he is my cousin brother. This is 40-year-old. You can see the mobility at the fracture site and there is stable pseudoarthrosis. He was driver in police department and was able to perform all activities in spite of the non-union. This is another case, lower end of the femur completely shattered and there was mediolateral instability, and you can see the patient's activity, weight bearing with the brace, no problem. Thanks for your kind listening. Jai Hind, Jai IOA.